Hello, everybody, and welcome to Pediatric Grand Rounds, everybody here in the audience and on Zoom. I think Dr. Hirsch is joining us over Zoom today, so he will not be here to welcome us all in person. It is a great pleasure to introduce today's speaker, Dr. Shabnam Pevandi, who is one of our pediatric cardiologists here at UCSF, co-director of Healthy Hearts and Minds program and associate director for the fetal cardiovascular program. Dr. Pevandi did her pediatric training at LA Children's and then went on to CHOP, where she did her cardiology fellowship and then another fellowship in fetal cardiology, and then joined us in 2008 at UCSF, which just makes me realize time flies when you have fun. No, am I wrong?
2013.
2013?
I'm not that old.
Oh, sorry. I meant to say 2018, but it's 2013. 13. Yeah, sorry. See, I'm doing this out of, like, I knew my memory was not going well here, but 2013, but it seems like yesterday, and it's 10 years ago. So she's been here for 10 years. She did her master's in clinical research here at UCSF and is leading a really fascinating research program funded by R01 grants and other funding mechanisms on the neurodevelopmental sequelae of congenital heart disease. It's probably more complicated than that, but that's my summary. And I'm delighted that she's here to give pediatric grand rounds.
Thank you. I hope everyone can hear me on Zoom as well. Thank you for the introduction, Sandrine, and thank you for the invitation to go over what we've been learning from our research program here at UCSF. So I wanted to start with just some basic epidemiology of where we're at when it comes to congenital heart disease. And we've seen some dramatic improvements in congenital heart surgery over the last 2 decades or so. This is a US-based sample looking at discharge mortality rates. Do I have a pointer? Look at that. Anyways, okay. Looking at discharge mortality rates by severity of congenital heart disease from 1998 to 2014. And if you look at that top line there, that's the most severe forms of congenital heart disease. We can see that over the last couple decades, there have been improvements in discharge mortality rates over time. And this is, thank you. This is in large part due to advances in operative techniques in the OR, as well as the perioperative care that's being provided to our patients both before and after surgery. So back in 2016, this article was published, which went over the sort of where we stand when it comes to epidemiology. And in the year 2010, the prevalence of congenital heart disease in the US population was estimated to be about 2.4 million people. And if you break that down by age group, this was comprised of about 1 million children less than the age of 18. And, okay, thank you. And then 1.4 million adults greater than the age of 18. So this is the first time that we saw that the number of adults living with congenital heart disease had surpassed the number of children in the United States, and really speaks to this improvements in survival that I mentioned earlier. And this is all good news. survival is always good, and they're surviving these very complex operations, but there's been sort of a trade-off as well, where we're seeing an increase of comorbidities as well. And it turns out that the most common comorbidity our patients face with major congenital heart disease is neurodevelopmental impairments. And in the contemporary era, it's estimated that over 50% of our patients with major congenital heart disease have some degree of neurodevelopmental impairment across the lifespan. And it's not just objective measures like IQ, but includes other impairments in school, for example, where there's been high rates of behavioral problems reported, the need for remedial education or repeating a grade, all of which can contribute to difficulty attaining independence as they go from the childhood age to adult, as well as societal contribution. So this has led to, I think, really an explosion in the literature. Not just us, but many, many other investigators have been looking into what influences neurodevelopmental outcome. This is really just a sample of papers from the literature. I'm sure I'm missing some important papers here. But most of this work has really been focused on the early time period. There's been fetal risk factors identified, such as whether or not you're prenatally diagnosed. There's been several postnatal risk factors identified, such as prematurity, time to surgery, intraoperative factors, as well as postoperative factors like how long do you stay in the hospital before you get discharged home, as well as more recently, we're learning that socioeconomic factors in the home environment play a very significant role in this particular outcome. So here at UCSF, we've also historically focused on this snapshot in time as well, the fetal and neonatal brain and congenital heart disease. And I was really fortunate when I joined here 10 years ago. There was an ongoing group of researchers studying the brain in patients with congenital heart disease. And back in 2001, Patrick McQuillan, who's one of our cardiac intensivists, and Stephen Miller, who was here at the time, started a prospective cohort study with the goal of understanding brain development and patterns of brain injury among newborns with complex congenital heart disease. So they started this study. This was the basic structure of the study, where they consecutively enrolled full-term newborns, mostly that had transposition of the great arteries or single ventricle forms of congenital heart disease. Both of these groups typically required neonatal cardiac operations, and they excluded those with known or suspected genetic abnormalities. These patients then underwent a preoperative brain MRI, underwent their cardiac operation, and then had a postoperative brain MRI before going home. And then were asked to come back for neurodevelopmental testing at various time points. So there's been many, many important papers that have come from this prospective cohort study, and I'm just going to highlight two of them. The first was a New England Journal of Medicine paper that was one of the first to observe that newborns with congenital heart disease have delays in brain development. This was done using magnetic resonance spectroscopy and measuring important metabolites in the brain, where they identified that full-term babies with these complex forms of CHD had lower levels of N-acetyl aspartate to choline compared to full-term babies. And the levels in the CHD babies corresponded to what is typically seen at 34 weeks in premature neonates. So although these babies were being full term, their brains were about 4 to 6 weeks delayed. The second main observation was that neonatal brain injury is common in complex congenital heart disease. In our experience and in several other institutions and other prospective cohort studies, it's estimated that up to 2/3 of newborns with complex CHD have evidence of brain injury, a third have injury preoperatively, and a third have newly acquired injury postoperatively. And this is typically in the form of white matter injury, as you can see in the top panel here, or small focal strokes, as seen in the bottom panel here. So subsequent to some of these papers, there's been additional groups studying this patient population. And one of the other major observations that came from this work from Kathy Limperopoulos and her colleagues was the observation that these delays in brain development that were observed in newborns actually begins in utero. So in this study, they used fetal brain MRI to quantify total brain volume and compared a group of complex fetuses with complex CHD to controls, and found that the fetuses with congenital heart disease had significantly smaller brain volumes compared to controls. And the blue line is the fetuses with CHD. And interestingly, this divergence between the two groups really begins in the third trimester of fetal life. And this makes sense when we think about the normal circulatory physiology and normal brain development in utero, where we know the third trimester is marked by a period of rapid brain growth, and the heart responds by increasing the cardiac output to the brain in the third trimester. And in the setting of structural congenital heart disease, you can imagine that relationship doesn't work out so well. So now fast forward about a decade or 12 years later, we're now starting to see that these observations actually do influence developmental outcomes down the line. This is work from the group in Boston, where they enrolled fetuses with complex CHD as well as controls, performed serial fetal brain imaging, and had these patients come back for developmental testing in infancy. And they found that within the congenital heart disease group, a larger fetal total brain volume correlated with higher gross motor and general adaptive outcomes at 18 to 24 months. And this was after adjusting for all the other known risk factors for neurodevelopmental impairment, like clinical and social factors. So this is one of the first papers to show us that these observations that the brain is small in utero appears to have a lasting impact on neurodevelopmental outcomes. So this really begs the question then of what causes delayed fetal brain development. And as we all know, the fetal brain is a very dynamic organ. And here in this video, just by looking at the surface of the brain, we can see that there is a tremendous amount of growth and change that occurs during gestation and in those first few weeks after birth. And the field has sort of settled on the fact that there are multiple etiologies to this delayed brain development within cardiac patients. So as a fetal cardiologist, I'm mostly interested in the role of cardiovascular physiology in utero and how that relates to these delays in brain development. But we've also learned that there are genetic underpinnings, as well as more recently, the importance of the maternal fetal environment and social determinants of health, which I'll touch on at the end of the talk. So about 7 years ago or so, we started the fetal heart and brain study, where we had three main goals. The first was to understand the causes of delayed brain development and congenital heart disease. The second was to identify fetal predictors of neonatal brain injury and neurodevelopmental outcome. And the third, more long-term goal was to identify possible neuroprotective agents in fetal life. So as I mentioned, I was very lucky that I joined this existing research group, which allowed us to basically extend the existing prospective cohort study by basically adding a third imaging time point during the fetal period, as you can see here. So now patients that were enrolled were undergoing serial imaging once prenatally, twice after birth, and then are being asked to come back for neurodevelopmental testing. So let's start with this first bullet point of understanding causes of delayed brain development in congenital heart disease. So I'm very interested in the role of cardiovascular physiology. And one of our main goals initially was to identify new imaging tools in utero that can provide us with efficient yet quantitative information about the fetal brain. So I have to say, this really required me to step outside of my comfort zone. I'm a fetal cardiologist. I don't do MRI. I'm not a neurologist or a radiologist. So it required a lot of collaboration with very smart people like Duan Xu and Jing Lu that are pictured here. And we settled on T2 star MRI, which is a very widely used tool for different clinical applications. It's used for perfusion and iron deposition studies, for example, in adults. But the basic concept is that it measures relative levels of deoxyhemoglobin in the tissue of interest, such that the deoxyhemoglobin content is inversely related to the T2 star signal decay. So the shorter the decay time in milliseconds, let's see if this works. Okay. Shorter the decay time in milliseconds, the more deoxyhemoglobin in that tissue of interest. So the way I think about this is looking at the tissue levels. So it's sort of like an MRI version of NIRS for the fetus. And so we start this first study that we did, we enrolled a group of fetuses in the third trimester with congenital heart disease. They had varied forms of congenital heart disease, but mostly had hypoplastic left heart syndrome or transposition of the great arteries. And we also enrolled a group of control fetuses that were recruited from our low risk obstetrical clinic here at UCSF. And the first thing we did was to replicate the findings that the brains are in fact smaller in fetuses with congenital heart disease compared to controls in the third trimester. And then we looked at this measure of T2 star decay time, and we found that overall, cerebral tissue oxygenation was significantly lower in fetuses with complex congenital heart disease compared to controls. And when we broke this down by type of congenital heart disease, transposition, and hypoplastic left heart syndrome, these two groups for the non-cardiologists in the audience are very different physiologically, but they both had very similar levels of this T2 star decay time, and both were significantly lower compared to our control group. So this first study, I think, allowed us to identify this tool that allows us to assess cerebral physiology efficiently in utero, that we are hoping to continue to use in our ongoing observational studies, as well as potentially in future trials that would study neuroprotective agents. Right now, we're working on how this measurement corresponds to ongoing brain growth, as well as risk of brain injury and neurodevelopmental outcomes postnatally. Okay, so moving to the second bullet point, which are to identify fetal predictors of neonatal brain injury and neurodevelopmental outcome. I'm going to come back to this figure here, which I showed earlier, that neonatal brain injury is common in our newborns with complex congenital heart disease. And for the longest time, these injuries have been termed clinically silent because they were really only observed on the basis of research protocols. Most of these newborns did not have overt neurologic findings prompting an MRI. At least when a cardiologist is doing the neuro exam, we didn't see anything. So it was really important to determine whether these injuries actually corresponded to developmental outcomes down the line. So we did this study a few years ago, which was it's sort of a culmination of that prospective cohort study that Patrick and Stephen started back in 2001, where we looked at the relationship between these newborn brain injuries and developmental outcomes in infancy and early childhood. And we found that in all of the patients, regardless of the type of congenital heart disease, transposition or single ventricles, those with moderate to severe white matter injury as a newborn had significantly lower motor scores at 2.5 years of age compared to those who had none or minimal white matter injury. And just to put this into context, we're talking about a 1 standard deviation decrease from the general population. So these are not huge deficits, but clinically relevant decrease from what we would expect. So our next step then, knowing that this is an important measure, the degree of brain injury, was to explore risk factors for brain injury, and in particular, whether these observations of having a smaller brain in utero increase the risk of brain injury after birth. So this is a study, a multi-center study that we did with our collaborators in Toronto, where we pooled our brain imaging data. This included patients with HLHS and transposition. They had two imaging time points, once in utero in the 3rd trimester, and then again as a neonate preoperatively before going to the operating room. And what we found was that the fetuses that had smaller brains were more likely to go on and have moderate to severe white matter injury after birth and before the operation. So our interpretation of these findings is that perhaps a smaller, more immature brain predisposes these neonates to injury, along with several other risk factors that take place during this time course, beginning in that perinatal time period. But it also did establish to us that perhaps brain injury, and more specifically white matter injury, is an important intermediate outcome measure. Some of these studies are often plagued with, we have to wait so long until we can achieve our primary outcome for developmental outcomes, that it seemed nice to have this intermediate outcome measure that seemed to be a good indicator of what we would expect down the line in terms of developmental outcome. But we wanted to study this a little bit more, especially in the context of this figure, where we already talked about that there's been these improvements in outcomes overall in congenital heart surgery. So we wanted to see whether other outcomes carried a similar pattern, including rates of brain injury. And we had this, unique opportunity to do this here because we've had this prospective cohort study for the last 20 years. We could actually study the temporal trends of white matter injury over time. So this study was actually published about 2 months ago, where we looked at our entire sample of patients over 20 years. We had enrolled about 270 newborns, of which 258 had, most of them had both a pre and a post-operative brain MRI. And then we categorized these patients based on year of birth into epochs of time, beginning in 2001 and ending in 2021. So first, we just looked at preoperative white matter injury separately. And what we found was that there really has been no change in the probability of preoperative white matter injury over the last 20 years, that the rates of injury have remained relatively constant over time. But in contrast, we saw a very different pattern when we looked at newly acquired post-operative white matter injury, where we saw a progressive decline in these new injuries that were happening after the surgery, such that the probability of new post-operative white matter injury decreased by almost 20% from 2001 to 2021. So this was really interesting to us, and we decided to dig a little deeper and to try to identify whether there were clinical contributors that can explain these findings. And there's the obvious that we couldn't control for. Obviously, over a 20-year period, there's a lot of personnel changes and confounders that we can't account for. But we had also collected several clinical data points, both intraoperatively as well as postoperatively, particularly in the first 24 hours after the surgery. And I don't have a whole lot of time to go into all of these variables, but just to say that the one clinical variable that could in part explain these findings was the blood pressure data. So this is looking at the blood pressure data in the patients with transposition of the great arteries. What we're looking at here is the mean and 95% confidence interval for systolic, mean, and diastolic blood pressures. And we can see for transposition in the most recent era of time, there were trends towards higher diastolic and mean blood pressures compared to the first epoch of time. And these trends were even more obvious when we looked at the single ventricle patients, as you can see here, where the blood pressures were significantly higher more recently compared to earlier in the study cohort. And the data that I'm not showing is, of course, this was reflected in, we observed changes in practice patterns in our cardiac ICU with regard to inotropic use. We've started using more epinephrine, less milrinone, which can probably lead to these changes in blood pressure. So to summarize this data, we found that overall, looking at primarily two forms of complex CHD, transposition and single ventricle patients, we've really seen no change in preoperative white matter injury rates. However, we've seen a progressive decline in new postoperative white matter injury. What the data that I didn't show is that this is in the context of longer support times in the operating room, which may just reflect our patients have become more complex recently. But despite that, we're still seeing this decline in new postoperative white matter injury. And the one factor that we can identify that may in part explain these findings is an improved hemodynamic state, and primarily the blood pressures in the first 24 hours after surgery. So when we put these two figures side by side, though, it was really interesting that we haven't seen similar trends for preoperative white matter injury. We haven't really made much improvement, and this continues to be a problem in our patient population. And I would love to say that this was really the premise, this data was the premise for the R01 that we got a couple years ago, but it did provide some supporting evidence for this R01 that was funded a couple years ago that's called TRANSIT-CHD. And this stands for the risk of acquired neonatal significant brain injury during perinatal transition in congenital heart disease. Some of you may be familiar with this study, especially those of you in the NICU who've really helped us get this study going. But this is basically, we're taking a longitudinal approach in this study with a focus on perinatal transition and specifically in transposition of the great arteries, just to keep the physiology kind of homogeneous. And we're looking across two sites, UCSF and sick kids at the University of Toronto. And we're using some of the same tools that I mentioned earlier in the talk. We're looking at some biomarkers prenatally, such as T2-star MRI as a measure of brain oxygenation. We're looking at measures of brain maturity through morphometry and diffusion. And then after birth, we're looking at clinical factors like duration of delayed cord clamping, as well as transitional physiology in both the brain and in the heart using combination of NIRS and echo. And our goal is to see how these factors individually and in combination lead to the risk of acquired postnatal but preoperative white matter injury. And the goal here is to identify what factors are the most important so that we could get to a point to lead to some neuroprotection during this important time period. So these are just the study methods spelled out in a timeline. And we're in year 2 of this study. And I just also want to thank the NICU for being so great in helping us get this study going and rolling. We enroll our patients prenatally, and they've been able to push these patients through that preoperative period. And we really appreciate the collaboration. So I want to spend just the last few minutes talking about another area that I've been interested in, and that's the maternal fetal environment and social determinants of health. And this is an area that not only applies to what we're doing here, but just in health outcomes in general. We are now very aware that social determinants of health is a very big factor in health outcomes. And unfortunately, congenital cardiology is not immune to health disparities that are being observed when we look at many, many different health outcomes. This is a data looking at a national sample of patients using death certificate data. And this was just recently published. And what you can see is that over a 20-year period, although there's been this decline in infant mortality rates secondary to congenital heart disease, there are persistent racial disparities. This top line here represents non-Hispanic Black infants, and this black line represents non-Hispanic white patients. So you could see there's been no improvement in this disparity over a 20-year period. And what's also disturbing is that we're seeing an increase in disparity between Hispanic and non-Hispanic white patients when it comes to infant mortality rates. So this has really led to another very important collaboration for me, working with these two amazing women here at UCSF, Laura Jelliffe-Pulaski in the Department of Epidemiology and Martina Sturr in our department, where we've taken this approach to use big data to understand health disparities in congenital heart disease. And our focus has primarily been in California using a population-based data set of all live-born infants in California that links birth, death certificates, and hospital admission records. And more recently, we've started to look at a more national sample. But our main goals initially have been what explains these racial and ethnic disparities. And we've been primarily focusing on very traditional outcomes like mortality and cardiac morbidities. And this is an important question because we know that race and ethnicity are social constructs. And so there has to be some other factors in the causal pathway that can explain these disparities. And we and others in other studies have found that there are several social determinants of health that sit in this causal pathway between race, ethnicity, and these traditional outcomes of mortality and cardiac morbidity. So things like educational level, insurance status, access to healthcare, income level, all appear to sit in this causal pathway. We've also explored whether maternal health conditions can sit in this causal pathway. There's been really interesting data that in children affected by congenital heart disease, there's a higher rate of maternal health conditions during pregnancy, like diabetes, preeclampsia, hypertension. And we also found that these conditions also sit on the causal pathway between race, ethnicity, and these more traditional outcomes. So this is, really important to take all of these factors into account when we're starting to identify these disparities when it comes to sort of traditional outcomes for congenital heart disease. But also it leads to us thinking about extending this type of work to other important outcomes like neurodevelopment, psychosocial health, and quality of life. But you can imagine now it's starting to get very complicated. I've talked a lot about clinical risk factors, about cardiac physiology. Now I'm bringing in maternal risk factors and social determinants of health. And especially when we're looking at the prenatal time period, there appear to be many, many intersecting pathways that may contribute to neurodevelopmental outcome later in life. So here's an example of that. We've talked about physiology of congenital heart disease that can lead to decreased oxygen and nutrient delivery to the brain, causing abnormal brain development. We're also learning that the placenta is a major player. Abnormal placental development can lead to impaired oxygen exchange and affect the heart. And then we've also learned that genetics and the genetic underpinnings can influence how the heart develops, how the brain develops, and how the placenta develops. And then we throw in maternal conditions that we know are more common when a fetus has congenital heart disease that appears to affect placental development. And then on top of that, you layer in social determinants of health, which is probably sort of an umbrella over this entire thing. So I want to spend a couple minutes talking about a more recent collaboration that I've started with other institutions to try to tease out some of these intersecting prenatal pathways when it comes to understanding neurodevelopment. And it's very important if we're ever going to get to a point where we start to think about neuroprotective agents to optimize brain development, we need to know which of these factors or combination of factors is playing the biggest role. So this is a collaboration with Caitlin Rollins, who's a neurologist at Boston Children's Hospital, as well as Cindy Ortnow, who's a neonatologist at WashU in St. Louis. And we sort of found each other because the three of us have developed these fetal cardiac cohorts with fetal brain imaging and very detailed clinical data, where it allowed us to apply for a grant. We got some seed funding from this foundation, Additional Ventures, that our goal being was to integrate multiple types of prenatal data to provide an accurate and generalizable tool to predict neurodevelopmental outcomes. And the interesting part about this work is really relates to the analytic approaches when you're dealing with so many different data elements. And when you have such a large number of variables, in our case, like our three cohorts, we collected something like 80 variables prenatally over time. And they're multimodal variables, meaning they come from different sources. They're clinical, demographic, imaging data. Sometimes traditional regression modeling can become challenging because either certain variables are left out of your model because it's understudied in the literature, and it's not determined to be important based on prior literature. Or if you use stepwise regression modeling, some variables may be included that are not clinically important. So this led us to start exploring these machine learning techniques, which is, again, not an area that I have expertise in, but my collaborators do. And the way I understand this, it's very much an agnostic approach to complex data sets. You're going in without any preconceived notions and identifies the best performing variables for the primary outcome of interest. So we've looked at some of our preliminary data. I'm not going to go into too many details because this is being presented at the PAS as an oral abstract in a month or so. The first author is Zach Versoulis for this study. But for this first pass, we really just pooled our data of single ventricle patients. So these are fetuses with single ventricle congenital heart disease that also had neurodevelopmental testing done at around 2 years of age. And our primary outcome was the presence of neurodevelopmental impairment at 2 years, which we defined as having a Bayley's score of less than 85. So for those of you not familiar with Bayley's, that's basically one standard deviation below the general population. And about 29% of this population met that primary outcome. So the first approach we took, I think more of the group might be familiar with this first approach, which are these classification trees, also called recursive partitioning, which basically it is sort of a more simpler machine learning approach, but it identifies variables and dichotomous cut points within variables that most correctly distinguishes or classifies the primary outcome of neurodevelopmental impairment. So with this approach, we found, going from right to left, the yellow represents the neurodevelopmental impairment, that neurodevelopmental impairment was more common in those from a low-income group, those from a non-white race, and those with systemic outflow tract obstruction. So for those of you who are not cardiologists, single ventricle patients can either have obstruction to the aorta, which feeds the brain, so that's probably bad, or they can have obstruction to pulmonary circulation. And it's not surprising that systemic outflow obstruction is going to be worse than if you have obstruction to the pulmonary circulation. So here in this first approach, we're seeing these demographic factors are really coming out as being the most impactful when it comes to neurodevelopmental impairment within a congenital heart disease population. And then we compared it to the second approach, which this is where it gets really outside of my realm of expertise, but these are these deep learning models, software that applies an algorithm to identify the best performing variables among all of the predictor variables. And in our case, it was like 80 variables. And it basically reduces the model to the fewest possible variables that perform the best in predicting the primary outcome. And then that final set of variables is tested on a validation cohort to determine the accuracy of the model. So the way to look at this plot is basically the positive values on the x-axis here represent an increased odds of having neurodevelopmental impairment, while the negative values indicate a lower odds of having neurodevelopmental impairment. And the dots, if we take white race, for example, the red dots represent white race, while the blue dots represent non-white race. So this model also identified that the variables predicting a lower risk of neurodevelopmental impairment included older maternal age, white race, and higher income. And some other important fetal factors emerged from this approach as well, including having normal genetics, which makes sense, no systemic outflow tract obstruction, as well as a measure of placental health with the flow in the umbilical artery. So this is very preliminary data. It's definitely not ready for a paper or anything, but it was interesting to us that when we looked at these two approaches, these demographic factors were emerging as being very important when it comes to neurodevelopmental impairment. So, and it was, for us, it was very interesting because for the longest time, we've always focused on it's all about the heart. It's the heart that's leading to these neurodevelopmental differences. But clearly, there are other important factors that we have to take into account, such as sociodemographics. Okay, so finally, I want to just end on the clinical aspects, because this is why we do this work. This clinical research is how do we apply this to our patients so that they can benefit from this type of work. And as I mentioned earlier, neurodevelopment in congenital heart disease is unique. It's unique compared to other populations, but it's also very dynamic. And by that, I mean, even if a baby as an infant has developmental screening and they look perfectly fine, it doesn't mean that they're fine for the rest of their lives. Many of those infants go on to have difficulties with language, behavior, and learning difficulties later in life. And as a fetal cardiologist, when we counsel patients after we diagnose complex CHD, we often tell families this is going to require lifelong care with a cardiologist. But I think it's equally important in the same vein to say that this is going to require lifelong attention to development and behavior as well, because it makes parents an advocate for the child to make sure they're getting on-time developmental screening and early intervention, because all of these difficulties that I reviewed, most can be overcome if they're identified early on, whether it's through physical and occupational therapy in infancy, speech and language therapy in childhood, or learning support and school accommodations later in life. So this is one of, I think, many areas in our field of congenital cardiology where I really think the research helped inform clinical programs. And we've seen this nice translation from the clinical research into it coming into the actual clinical care of patients. So in most heart centers across North America now, there are specific neurodevelopmental follow-up programs embedded within the heart center to monitor these developmental outcomes in our patients. And this is the model that really seems to work the best in terms of delivering the care to these patients, because in many ways, the cardiac patients see the heart center and their pediatric cardiologist as their medical home. And so integrating neurodevelopment, psychosocial, and mental health into the heart center model really ensures delivering that care to our patients. Now, as you can imagine, this is very financially challenging. It requires institutional and heart center investment. We, like many others, have had to depend upon philanthropy to get these types of programs up and running. But it does help that there has been a push both nationally and internationally on the importance of this outcome and that it's the most common comorbidity. For example, the Cardiac Neurodevelopmental Outcomes Collaborative started about 10 years ago, which is an international clinical registry tracking neurodevelopmental outcomes that allows us to track quality and best practices of our patients. And many of us are involved in the leadership structure for CNOC as well. What I don't have here is that neurodevelopmental follow-up is now a line item in the US News and World Report. So it's really making its way into it becoming just standard of care. We shouldn't have to depend solely on philanthropy to make sure our patients are getting this type of care as they move through our centers. So here's our program here at UCSF. Is called the Healthy Hearts and Minds program. This is Stephanie Cox, who's our neuropsychologist, who's sort of my amazing partner that's helped build and develop and sustain this program over time. I would say we're one of the younger programs in the country, and we were really fortunate to partner with our neonatology colleagues in the high-risk infant follow-up program, where all of our patients undergoing neonatal heart surgery get developmental screening through high-risk infant follow-up. After they graduate from that program, they move on to Healthy Hearts and Minds, where they get neuropsych testing at important time points in life, preschool, pre-adolescence, and then again in adolescence. And then for those of you that might be aware, very recently, there's been several of us in the Heart Center that have initiated a program, primarily Lori Feynman and Martina Sturr, developing the Neonatal Cardiac Center of Excellence here in the cardiac ICU. And I think this really stemmed from a few years ago, we got together and developed what's called the Neonatal GRAND program, which stands for Growth and Neurodevelopment, that provides inpatient developmental care for newborns with complex congenital heart disease. And this program has really taken off thanks to Lori and Martina and so many of the nursing champions in the cardiac ICU that have really pushed this program through. And I think it's going to make a very positive impact on our patients. So what are we still working on? Again, you know, we still have to, in many ways, depend on some philanthropic support. And we're hopefully going to have some psychosocial support, which I think is equally important, that would be for our families that we're diagnosing prenatally. We are working on routine neuroimaging in the early neonatal period, and when is it appropriate to do routine neuroimaging. Education liaison, which just allows neuropsychologists like Stephanie to communicate with all the different school systems within the Bay Area. And then very importantly, mental health services for our adolescents with congenital heart disease. So what do I see on the horizon in this area? I think we've had 1 or 2 decades of really mostly observational studies. We see these abnormalities, we know it's a problem, and I think we're now headed into moving towards prevention and preventing problems before they manifest. So I think we're going to start seeing more fetal and perinatal neuroprotection, clinical trials, once we can tease out what are the more important factors in that time period. Also, I think a lot of centers are now incorporating inpatient developmental care for the newborns with congenital heart disease. We've also seen some motor training in early childhood and executive function training for adults that seems to optimize some of those outcomes as well. So I want to end by, I think you can probably tell this type of work really requires a village. This, you could see that our research group here is incredibly multidisciplinary. We cross divisions and departments across UCSF. And I want to especially thank Patrick McQuillan, who's been my primary mentor and has really helped build my career in this particular area, as well as our support staff, Cassie Williams, Carla Silva, and Megan Martin, who helped the study keep it going, basically. And then our collaborators in Canada, mostly at Sick Kids and now in Vancouver, and our funding sources, including our grateful families that have contributed philanthropic funds. Thank you for your time, and I'm happy to take questions.
Maybe I can start with 2 questions from the audience on Zoom so that we don't forget about them. That was a great talk. Dr. Fernando Gonzalez says, hi, Shad, great talk.
Hi.
You mentioned decreased blood pressure goals after cardiac surgery, maybe decreasing progressive white matter injury. How does that translate to premature infants with TGA or single ventricle physiology who are already at increased risk of white matter injury? Do you see the same trends with blood management in preemies?
That's a really good question. Thanks, Fernando. And I'm going to say, I don't know, because that hasn't been really studied. And this interplay between prematurity and congenital heart disease and how it affects the brain, there's not a lot of great literature out there on these 2 conditions together. The good news is that Patrick, who I think is dialed in, just got funding for an R01 to study that very question and this intersection between prematurity and congenital heart disease and how it affects neurodevelopment, brain injury, et cetera. So it's a very good question.
And then the other question from the Q&A here is, what about for less severe congenital heart disease like VSDs that require open closure? What are those neurodevelopmental outcomes? Should they get neuropsych testing? And this, I think this probably comes from a community person. if we have a patient who had surgery through CSF, can we refer them for neurodevelopmental testing for preschool?
Yeah, so the first part of the question, actually, it's interesting because there's newer data. The Europeans actually, because they track a lot of their patients more carefully than we do in the US, that we're starting to see that even simple congenital heart defects like VSDs, they also experience some degree of developmental difficulties across the lifespan, maybe not as severe as if you have hypoplastic left heart syndrome, but enough that it does affect, academic achievement and quality of life. So actually, the American Heart Association right now technically recommends that any child who has open heart surgery before the age of 1 should have developmental screening. Our program here, because of the way that it's set up, we haven't been able to expand to that. So we focused on the highest risk patients, the neonates. But like VSDs would totally fall into that category. And I would say for anyone in the community that has a patient there, that has had open heart surgery that's not plugged in, please refer them. We're happy to see them. They won't qualify for high risk infant follow up, but they would qualify for our Healthy Hearts and Minds program.
Thanks for to your T2 star finding. Do you find any differences in brain volume? And then how has this different oxygen delivery impacting how you get that?
I'm just going to repeat your question just for the people on Zoom. You asked first, do you see regional brain volume differences? And the second was about metabolism of the brain. So the first question is, we haven't analyzed our data yet looking at regional brain volumes. We've really just looked at total brain volume, but there's been several groups that have looked at regional brain volumes in the fetus. And we do see that there are certain regions that are more at risk, like the white matter, for example. In terms of your second question, in terms of metabolism, we're actually, the data that I didn't show is, I think of T2 star is sort of measures metabolism, I guess, because you're looking at oxygenation at the level of the tissue. So it does appear that metabolism is not normal in the fetus with complex congenital heart disease. But I also think of how that impacts autoregulation, for example, in the brain. And some of the data that I didn't show is we're looking at how maternal hyperoxia used in the 3rd trimester can tell us how the brain is regulating itself. And we're seeing some really interesting findings where the fetuses that don't seem to be regulating well have smaller brains overall. So hopefully if I come back in a year or two, I can go over that data, but I think all of that is important. And I don't think metabolism is normal either.
So you showed the data that the pre-surgical white matter injury had not changed, but the post-surgery had declined. And I was wondering to what degree there's actually also a difference in the denominator in terms of the number of kids that actually survived the very early neonatal period and the number of premature patients who go through surgery, etc. Because perhaps it's actually like if you would correct for that, the improvement is even more so, and just there are some other founders that make it that it hasn't improved.
Yeah, that's a really good point. If I think I understand it, you're saying it was there maybe mortality was differential by time period. We looked at things like mortality and also, going on ECLS postoperatively across the time periods, and it didn't seem to change much across the 4 time periods. That seemed to be pretty constant, meaning there weren't periods where mortality was higher. I think one of the things that has been brought up that we're going to explore is some people have brought up, well, maybe this is because these patients left the operating room with a technically better operation. And so they're more hemodynamically stable and can tolerate epinephrine and can tolerate higher blood pressures. And so one of the things we're interested in looking at are things like technical performance scores coming out of the OR and whether that has changed over time, and that can sort of contribute to these findings. But I think you're speaking to also, there are many factors I think we can't account for in this data, where you're looking over a 20-year period, but it's still interesting that we're seeing some of these practice changes that may translate into a better hemodynamic state.
I have to say, as a former CICU doc, I remember very well when Dr. Reddy joined the group and stopped the use of milrinone post-op, and we were all like, "That's crazy." It's kind of a little painful to have to tell him now that maybe he was right.
I know. Yeah, I know.
Yeah. Is he saying I told you so?
Yeah, totally. Yeah, totally. Yeah.
Other questions?
Okay.
All
Thank
right,
you. Thanks, everybody.